Aboriginal people, when you ask them about how will they bounce back from 10 years of drought, they'll say, this is not new to us. We know how to get through it. That's a statement of resilience, because out of hardship, they know how to bounce back. So things we could learn from the strategies of Indigenous communities. First of all, there's Aboriginal medical centres, or Aboriginal medical organisations, which are community controlled. And they are set up on the main street, quite often in an old pub, an old hotel, which is both spiritually and in many other ways familiar territory. So they come to the old pub, but they come there. Now it's just for health services. There's no beers offered. So they get a sense of control because there's a community representative board. They say we recognise ourselves by having familiar people like us working for us, so that engenders trust. It's often based in the mingling centre of the communities, right on the main street, where for some reason we put our community health centres and our hospitals out the back of the community because we have to be on high ground for when there are floods out there. But we don't learn that we need to be on the main shopping streets. So the Aboriginal population knows something that the wider population don't know, and they're consulting continuously with their community, re their needs for service. So it's not just a one-off consultation, they're always consulting. And then there's the issue of them saying we will do the traditional and the contemporary solutions together, this and that together. Our consultations indicate that most Aboriginal communities value doing both. And there are a number of books now, which I have just put down there, that now suggest historically that it was always so, that the Aboriginal people always welcomed white input and wider communal input, and were always wanting to do collaborative things. So that the wars that occurred were out of the encroachment of land and on their custodianship. So there have been resilience-enhancing opportunities. First of all, the Aboriginal land councils have got into carbon credit trading and buyback offset schemes. They've got into wind farming on the eastern seaboard. They are buying up land that has been discarded because of the drought, and they're now being able to have ready access to it for the custodianship of the land, because they say the land does not belong to us, we belong to the land. And then there's mental health first aid, which is like physical first aid, developed by Betty Kitchener in Melbourne, but now has been translated into many different languages. But there is an Australian Indigenous version of that, which they can learn, which develops more resource people in their community. And then there's Pit Stop and Kicking Goals programs. The example of Pit Stop is that men don't care about their health in Aboriginal communities, they care about cars. So if you can start saying, if you look after your skin, it is like looking after the panels of your car. If you look after your what goes into your mouth, it's like looking after the fuel supply. In many ways, we're trying to reconcile the dilemma between traditional and contemporary, between collectivist values and between individualistic values. Where the priority in collectivist values is to preserve kinship network and share everything, share any money that comes into the community, and quite often goes on drugs or on beer. Whereas with individual careers and individual ambition, you usually have to go to a regional centre or a city to work out how you're going to get on with your education, and that dislocates you from your community. So there are upsides and downsides of both of these. And I just direct you to Eva Tuck at the bottom there in the yellow, that we should not be having any more damage-centred studies. We should not just be thinking of ourselves as broken, but considering people as desire-based, aspiration-based, and caring deeply about their futures and their kids' futures, and not just looking after themselves in the buffeting present. This idea of having a view to the future. We won't cover some of the evidence because of the time. Now, assertive community treatment teams for urban homeless with mental illness. There's much evidence that assertive community treatment that is very low caseloads with people who work holistically with their clinical problems and with their functional problems, and help them with banking, and will help them with shopping, or will help them go to the doctor if they have physical needs, etc. One team working 7 days and nights a week. And in a meta-analysis, there was 37% greater reduction of homelessness and 26% of greater reduction in psychiatric symptoms with homeless populations. This is a very comprehensive study in the American Journal of Psychiatry. And then there's a number of research programs that have been proved very successful, but then were dismantled due to local health politics who did not believe in this assertive work. One of these studies was done by Marie Thiessen in Sydney, and another was done by Isaac Marks and Matt Mugen in London. And however successful they were, because of the local politics that did not want to see these things succeed for whatever reason, they were dismantled after they'd already showed a very powerful effect. Now, there's also evidence that assertive community teams can be adapted for regional and remote settings with Indigenous people with mental illness. This is a statewide initiative in our state of Queensland, which provides holistic care, providing psychiatric and physical care, and linking with appropriate other community services. We were talking about one-stop shops. Well, this is a one-stop mobile shop, and the scores in terms of their fidelity criteria are very high. The next example, and really the last example I want to raise here, is this issue of Headspace. Headspace is a program for youth with mental illness problems. It was established and funded by our federal government in 2006, and there are 60 centres so far funded, and this is to double over the next 5 years. This was only announced last Tuesday. This is hot off the press, folks, in our federal budget. They are youth-friendly. We heard about being youth-friendly this morning, and youth-trained staff, including GPs, who are very youth-focused and trained. And they have a one-stop shop where you can get, first of all, your general health care from the general practitioner, your mental health, your drug and alcohol and sexual health, HIV if you need it, social support, information, and social services. And it's for young people aged 12 to 25 years and their families who won't approach not only mental health services, they won't approach any health services. But this is an initiative of mental health, but it's bringing some young people who would never go near general health services either in for care. And it also provides mental health promotion for all young people. They set up these stalls at festivals, and they have a lot of free spots on television late at night. Now, this is the first of them to set up, and this was in a shopping centre on the first floor, so it's a little bit private, but if you're there to go to the cinema, you can also say, I've got to go and see the doctor. Now, nobody minds you going to see the general practitioner amongst your friends, but then once you see the doctor, he says, or she says, you need to see a mental health professional, you might need to see a psychiatrist, then they can bring all those people in. They can bring in the drug and alcohol people, etc. This is the waiting room. Sorry about this. This is a regional centre. This is not in an urban setting. This is now in a regional, rural setting. This is another rural Headspace program. Remember, there are 60 of these, and now we'll be doubling that over the next 5 years. And they're pretty funky inside. And there's a lot of decoration. Most of the decoration is done by the young people, or with designs inspired by young people, and with furniture that they choose. So you can see it's very colourful. And some of the pictures, that says Headspace, but it's done by a graffiti artist. We'll finish with the human rights implications. How long have I got, Benedetto? Thank you. The key contradiction is that there is an overuse of involuntary care in English-speaking countries compared to Italy, and particularly compared to places like Trieste. We vastly overuse involuntary care, both on an inpatient basis and community treatment basis. You could say the same about the United Kingdom, about North America, etc. But on the other hand, we have good evidence on Australian data that timely use of involuntary orders works to reduce violence. For instance, Steve Siegel from Berkeley has worked on our data to show that, and Olaf Nielsen and company in our country has shown that if you bring people in on an involuntary order when you first are worried about them, rather than waiting for them to do something dangerous, then there's much less chance of them doing something violent to themselves or to their family or anyone else. It's usually the family that bears the brunt. So, in a sense, there's a dilemma there. So that the implication is that we should use involuntary care much more sparingly, but earlier when warranted. Now, I think we've got to look at some pluralistic solutions for contradictory dilemmas and for untangling and balancing and celebrating complexities. And we have just completed a chapter on this, myself, my son and Pat McGorry. And then we need to train in and systematise ways of optimising voluntary care so that we systematise engaging in the community on their own turf and terms. That's where crisis services and assertive community treatment teams that go out to people, that are mobile, that will go and meet you on your own turf and terms are important. And shared decision making like Patricia Deegan and Robert Drake's work, living wills, relapse signatures, early warning signs, manifestos, individual recovery and wellness plans, involving the families in becoming partners in this work and not excluding them, and invoking traditional healing practices if this can be done in partnership. Some of the Indigenous traditional healing practices are very relevant to Western communities done in conjunction with good clinical care. So we can all be more effective if we are on the same page. And there's a recovering consumer, and there's a recovering family, and there's a recovering psychiatrist, which I hope I am as well. So just to remind you of some of the candidate solutions we have just looked at. At the cultural level, we're saying this and that, traditional and contemporary. We're also saying one-stop shops for vulnerable populations where we do both physical health as well as mental health, drug and alcohol, sexual health, every other sort of health and social services in one site that they find friendly to that population, to that age group, and also to that cultural group. We should have one-stop shops really for every age group and for every phase of care. But they also need to be set up in a way that they can go out to people in their homes and do things on their own turf and terms if they're not ready to come into you. They're not supposed to be just set up on a sedentary outpatient basis. They should be in the middle of their community as well. And at the individual and family level, we need assertive community treatment team adaptations for the most marginalised and vulnerable clientele. This works for homeless people. This works well also for the next phase after early intervention, as has been shown in our country. And Headspace and other one-stop shops with mobility in and out of office hours. Thank you.